So I am so sorry not to be with you in person, and I will be live for the Q&A, but I wasn't sure how much voice I was going to have, so I decided to record the talk portion. This is a topic that certainly I didn't get any training on when I was a resident, how we get from the work we do in terms of interpreting images to the reimbursement for those imaging, how a dictation becomes $1. I often say that this formula, which is the formula that Medicare uses to construct physician payments, can tell us a lot. I would say everything we need to know about how we deliver healthcare in this country, where we have gaps and where we do too much. You can see at the end whether you agree with me. A couple of sort of framing principles. The first thing is you have an excellent professional organization representing your interests. The American College of Radiology is essentially the voice of radiologists with policymakers and payers. But whether it's navigating for the resources you need in your institution, whether it's understanding within your health system how you stack up against other departments in terms of being a revenue generator or a cost center. It's important to know the basics. It's important to know the economics and the way the money flows. And even though a lot of the policy I'll talk about is national, you'll also see that whether it's through your individual negotiations with commercial payers or your negotiations with your health system, there are definitely a lot of important local context to how we get paid. You may have heard of this sort of notion that we have to shift our healthcare payment system from a volume-based system or fee-for-service to a value-based system. Frankly, people have been talking about that for many years, and it hasn't happened. Certainly at Weill Cornell, we're probably 98% fee-for-service. But I really increasingly believe that we are going to have to find a way forward for radiology reimbursement that isn't volume-based, whether it's burnout or whether it's the very real future that we have, where we will start to see artificial intelligence augment our performance and perhaps take away some of the routine tasks. We're not going to do well if we're getting paid on a fee-for-service model in that regard. So it'll be difficult, but I think we have to keep working at it. So this is kind of a revelation for me. I started my first job at Montefiore Hospital in the Bronx, so big mission-driven teaching hospital. I was asked to start essentially an equivalent private practice in the community. I couldn't believe that we would do the same service on different patients and we would get paid wildly different amounts of money. And these numbers are more current than when I started practice in the mid-90s, but the question of how much do physicians in New York City get reimbursed for screening mammogram? Well, the answer is all of the above, from a low of about $100 for Medicaid, to very significantly different amounts for commercial insurance. And basically how you get paid by commercial insurance, so your Aetnas, your Uniteds, your Cignas, is absolutely predicated on your market power and your organization's ability to negotiate. So that is a significant difference. And when we talk about payer mix, the portfolio of your patients with these different types of plans, you will see how many patients you have in that Medicaid space is going to significantly impact the revenue into your practice or your ability to negotiate. So let's start with who it is that's paying, who's in that portfolio of payer mix. And we typically start with Medicare. All healthcare payment policy starts with Medicare. So signed into law in the 1960s by Lyndon Johnson. It's a federal program. So one program across the entire country covers the elderly, over 65, those with chronic disease. And everything that Medicare does is essentially in the public domain, in the federal rulemaking process, which means Medicare tells you what it's going to do. There's a comment period. Everything's published. It's funded by payroll taxes that you're all paying. Plus the beneficiaries pay a small premium, and they typically will pay 20% of the cost of their care, except for things like screening, which is covered 100%. Now, if you can't afford your premium or your 20% deductible or copay, if you're too poor for that, you're typically covered by Medicaid. That is an interesting group of patients to policymakers, if they are called dual eligibles, Medicare and Medicaid. We know that that's the group of people where we have significant opportunity to give better care and reduce cost. That's where we saw the biggest benefit of the Affordable Care Act, accountable care organizations. So this is part B I'm talking about, which is the physician services part of Medicare. hospital stays paid for in Part A, bundled by the type of diagnosis you have. So there's a bundle for stroke, there's a bundle for a heart attack, very different pricing. This Part C part, Medicare Advantage, is essentially where the federal government gives those Medicare dollars to a private insurance company and says, you administer it for our beneficiaries. What's good about that is that those companies have a lot of flexibility in how they provide coverage. They can often get rid of this 20% coverage. They can often include this Part D, which is the drug coverage that President George W. Bush signed into law. On the bad side, they tend to impose a lot of pre-authorizations and barriers to care that you don't see in the traditional Medicare program. Medicare, there's no really restriction in who can be a Medicare provider. I would say it's highly likely that the vast majority of you will participate with Medicare. I think most of us feel an obligation to take care of our seniors. And as I said, Medicare doesn't put a lot of barriers in the way of people providing care, other than, I will say, in imaging. So the notion that you can only provide certain types of imaging in the Medicare program, I would say has been very good for radiology. The Mammography Quality Standards Act, which was passed in the early 90s, which meant that you now needed to be accredited, and the ACR is the dominant accrediting body to provide mammography, got rid of hundreds of mammography units, often in family practitioners' offices. So really did restrict mammography practice to providers. That was extended in 2006 to require similar accreditation to provide CT and MR in the outpatient space. So those restrictions have been actually pretty good for us in radiology. Medicare has a fee schedule. As I say, it's published every year. If you participate with Medicare, that's the fee schedule you take. You can't say, I'd like you to pay me more. And you can't say, Mrs. Smith, you don't have to bother paying me that 20%. I don't need you to pay me that. If you do that routinely, Medicare will say, then I'm going to pay you 80% of the 80%. If you decide you don't like being a Medicare provider anymore, you can certainly leave, but you can't get back in for 2 years. I would say it's unusual for people not to participate with Medicare. So what does Medicare spend its dollars on? So you can see that there's a big chunk of it that's in this sort of commercial Medicare Advantage. It's a very popular program, 30–40%, depending on where in the country you are. Physician payments are not the biggest group. So here we have physician payments about 10%. But what, of course, Medicare knows about physicians is that our influence on this whole donut is much, much greater than the actual dollars that come to us, whether it's prescribing, skilled nursing facilities, hospital admissions. So, we punch well above our weight in terms of our impact on the Medicare program. So let's switch now and talk about Medicaid. Medicaid's a state level program. Every state has its own version of Medicaid, covers the very poor, covers a lot of poor children across the country. And it is a joint funding process between the federal government and the states with complex matching formulas. As I say, there's a lot of complexity, even within states, with different commercial versions of Medicaid being offered, different rules, different processes, and it typically pays less than any other payer. And a key provision of the Affordable Care Act was the expansion of Medicaid, which was great in many ways, but because the payments were so low, it was often very difficult and remains difficult for people who are covered by Medicaid to find access. Now, typically you're going to see, if you work in a large hospital system, you're almost certainly going to participate with Medicaid. But many private practices simply can't make it work at those rates. We do see some variability, again, not only in terms of the way the programs are constructed, but in the expansion of Medicaid, that was that cornerstone of the Affordable Care Act. Virginia did expand Medicaid. Many other states, especially those with Republican administrations, decided not to. That was an interesting decision, because what the Affordable Care Act did was it said, we're going to expand Medicaid. We're going to put more money into Medicaid. But what we're going to do is we're going to take away some of the ways in which we've been covering the uninsured, what are known as disproportionate share payments to hospitals. So I think what you saw in some of these red states was hospitals saying, to their administrations, okay, we know you don't like Obamacare, but what you've done is we're still caring for these patients. We have to, we have to take care of everyone who walks in the door. We're not getting the Medicaid, enhanced Medicaid rates, and we're not getting those disproportionate share payments. And so it was an interesting conversation and continues. So Medicaid. So commercial insurance, these are just a few of the mostly publicly traded entities, and some of them very large. United Healthcare, one of the largest publicly traded companies. As I say, they typically are going to mimic Medicare in what they cover. Not always the case. They may lag sometimes. They don't, if digital breast tomosynthesis was an instance where Medicare decided to cover it in 2015. It took several years for a lot of the insurance companies to start paying, and honestly, a lot of advocacy on our part. In terms of what you get paid, again, what I said, it's all about your market power and how you negotiate. Your rates will typically be a percentage of Medicare or a fraction of Medicare. So if you're doing well, and I will tell you that I have negotiated for my private practice, and I now have negotiated for a large academic medical center, and the spread on that is multiples. What commercial insurance companies do is they will contract with a certain network of providers. So if you're not in their network, you can't see their patients. The other thing to know, because it's sort of a player in the payer space, or the employment, the payment policy space that we don't often think about, which is that I don't know what you all have for your health insurance. So we have Aetna at Weill Cornell, but I'm not insured by Aetna. I'm actually insured by my employer. My employer pays Aetna to administer my health benefits, but it's their money, or actually my money, because I'm doing the work for them, right? And this is interesting because employers are, they are definitely a voice in how healthcare benefits are created, and something that we need to be aware of. These commercial insurance companies, obviously, for their clients, like large employers, want to provide health benefits, but do so with management of costs. And just as I mentioned with Medicare Advantage, they'll often use things like pre-authorization. If you've ever had to try and get an MRI for a sports injury, you know what that's like. And as I say, what you get paid by these companies depends on how effectively you negotiate with them. Another important piece of the who pays us pie is patients. Again, the Affordable Care Act was all about giving more people access to care and health insurance. And the employer mandates requiring health insurance certainly gave more people access to benefits. But what happened in parallel was we saw more of the costs of care. You were getting insurance, but you had to spend a lot more money before that insurance kicked in. The average combination of deductible, share of premium cost, co-pays, and every other out-of-pocket cost has gone up significantly. And then the other thing is, you will sometimes see people who are coming in and paying. I live in New York on the Upper East Side. It's a very affluent area. At one point, we had a pretty robust global health business, people who would come from countries where they would, pay for the cost of their care, hundreds of thousands. I would say some of that's largely dried up. But self-pay many times means no pay. And we know that the number of uninsured has gone down, but it is still, for many hospitals, a component of what they see, especially through the emergency department. So that's who's paying us. The next question is, how are they paying us? How are they deciding what to pay us for the services we provide? And this is the policy process that I spent a lot of my time in as an ACR volunteer. So I talked about fee for service, and there's a continuum where we start with fee for service, which is I perform a service, I get paid for that service. I perform 2 services, I get paid for 2 services. And on the far other end of that is capitation, which is essentially I have a population of people I take care of, and I get paid a monthly amount or a yearly amount to take care of them. So let's deep dive into that a little bit more. Just in terms of where we are, in this idea of having to go from volume to value. I hadn't given this talk in a while, and I think I used to have that arrow a little further along towards the bundle payments, capitation, value-based. But I think fee for service is hanging in there, so I moved the arrow to the left. So fee for service. It is how most of us, unless you are working in a Kaiser Permanente, a Geisinger, or even a Montefiore, it's how most of us are getting paid. And, you know, people look, you know, there are some people who, you know, think about it like it's the devil. And then there are some people who feel like it has worked very well. And, you know, if you're a good doctor and you do the right thing, it's a way that gives you more autonomy and control. And there's definitely some sort of political leanings there. There is absolutely no doubt that it incentivizes productivity and productivity-based compensation models, right? Those, you know, the RVU-based compensation models. What fee-for-service has never done is really effectively talked about the value of what you're doing. There are, you saw in the formula, there's a unit there, the RVU, the relative value unit. That value does not stand for value, how most of us would define it. So, you know, there are people performing services and getting paid for services, and those services are not adding any value. We, you know, have often said that perhaps 30% of imaging that's done has no value. That some of the great work has come from people like Krieg Askin at UVA. But that imaging was paid for. All of us have probably had people come in who are, you know, they've been ordered for test A. We know that test B would be better, but, you know, test A gets done. We read it. We may do a highly effective reading of test A, but if it wasn't the right test, it has no value. And we may get paid for that no value exam. A lot of what you've heard about value-based payments, specifically, especially the accountable care organizations, which were sort of again, a key provision of the Affordable Care Act, the idea that a health system would take responsibility for a population, and as long as they met certain quality metrics, if the costs of care for that population went down, that health system would share the savings with Medicare. We're in one, I'm sure you're in one too. We are still getting paid as fee for service in that ACO. The shared savings that we get come afterwards. Any quality bonuses are layered on top of fee-for-service. So it is essentially the foundation of healthcare payment policy. Now, the idea that you get paid, you do one service, you get one payment, you get two, is a little overly simplistic. There are a number of ways in which the fee-for-service payment is adjusted, and this is sort of some of the wonky science of payment policy. You know, you can tack a modifier onto the bill that says, you know, I had to stop the MRI because the patient was claustrophobic, so I need you to pay me something, but you don't need to pay me the whole amount. Or I did two of these, you know, contiguous body parts in the same day, and Medicare has decided there's some efficiencies there, so they're going to knock a little bit of money off there. There are, as I say, some bonuses, penalties for quality metrics, and then there are various other payments that sort of look at, okay, did you do this? Which site of service did you do? Did you do it in an office where you own the equipment, where you have to pay maintenance on that equipment and pay the staff? Or did you do it in a hospital where that's paid for by the hospital? So there's a lot in there, very much more than we're going to cover on today's study. So that's fee for service, far end of the spectrum. Bundled payments are something that healthcare reformers, you know, really felt was going to be a way to align providers around better care, lower cost. Don Berwick, who ran Medicare for President Obama in his first term, talked about the triple aim of healthcare reform, which was that we needed to make the population healthier, we needed to provide a better experience of care, and we also needed to do that at a lower cost. We've actually since added a fourth aim, which is the sort of health and well-being of those providing care. But so bundled payments, the idea was, well, why don't we bring people together? Why don't we, you know, create an episode of care? Now, this is not a new concept, and it is embedded in our health care payment system in many ways. So I talked about how we pay for admissions, hospital admissions. We don't pay the hospital for every service that the patient has when they're admitted. We pay them for their hospital stay, one payment. Care in a hospital outpatient setting, so the outpatient clinic of your hospital, again, is not paid for, you know, every little thing that gets done. There's a payment pretty much for the day that the patient is seen. Bundles can be big. They can say, you know, we're going to look at a joint replacement as an episode of care, or they can be small. We saw our CT of the abdomen and CT of the pelvis codes bundled together in 2011 with, unfortunately, a significant discount in payment. Creating bundles is much, much harder than it looks. When does it start? When does it end? Sometimes it'll seem easy, like joint replacement. Well, it starts the day of surgery. It ends after whatever physical therapy the patient has had to have. When you pay a group of providers a bundle, it's important to know who's going to be included in the bundle, who's going to be excluded. How do you manage a complication, for example? How are you going to pay the interventional radiologist who has to do a drainage when there's a post-op abscess? Was that included in the bundle, or should they get paid from another pot of money? Who gets to decide how the payments are divvied up? Liver transplant is something that is paid as a bundle. And I think in many institutions, it is the transplant surgeons that are really directing some of those decisions. As I say, surgical procedures are are really an attractive target because they're kind of, they're quite concrete. It's very much more difficult to think about stroke as a bundled payment, or diabetes. These are chronic conditions. Now, that said, an area that I think is potentially of great interest is imaging screening. So right now, you have your screening mammogram. It's paid for without any cost sharing. I showed you that 20% deductible that Medicare beneficiaries have to pay. Well, when you get your screening mammogram, because it's a preventive screening study, it's paid for 100%. Likewise, if you have commercial insurance, it's paid for 100%. But imagine you're one of the 10% of people that needs to come back for a diagnostic mammogram. That's expected, right? You read 100 screening mammograms. It is good practice for you to call 10% of them back. Those 10% of people, they have not won the lottery. What's going to happen to them is, however much their insurance requires them to pay out of pocket, now they're going to be stuck with paying for that diagnostic mammogram. So if you have one of these, plans where you pay a lot out of pocket, yeah, you might get your screening mammogram essentially covered 100%. You come back for a diagnostic mammogram and maybe you're paying several $100s for that. Work that we've done through the Neiman Health Policy Institute actually shows that patients are not only less likely to have their recommended follow-up if they have higher out-of-pocket costs, they're also less likely to come back next year for their screening mammogram. So I've been working with some others on the idea that maybe instead of just paying for the screening mammogram 100%, we should say, whatever happens to you, screening mammogram, and 364 days later, we are going to pay for as a bundle. And your provider will use that money to make sure you get the care that you need. Obviously, critically important to make sure that there are quality metrics in there so we don't have any misaligned incentives to not deliver care. But that's some ongoing work. So just to finish that sort of spectrum of payment, capitation is, again, what we say is, we've got a population of people, we're going to pay a certain amount per member per month for them, and you, healthcare provider system, are going to care for them. We saw some sort of penetration of capitation in the mid-90s when I was starting out in practice, and it was a total disaster. Not surprisingly, really, because we didn't have any electronic data. We didn't know who our populations were. We didn't understand, who had what chronic conditions, what people's behavior was. It was pretty much all paper. And then the other thing, I talked about some of the need to sort of layer in quality metrics. There were a lot of misaligned incentives. Providers were being told, you'll get your bonus if you keep the cost of care down, but nobody was really making sure that they were doing enough care. So it didn't work the last time. Now, again, there are some large systems, Kaiser Permanente being one of them, where it's embedded in the culture of the organization. You are seen by the organization, you are cared for. And that, they are all about reducing cost of care and providing quality care. But you really have to have the structure that your patients can't go elsewhere. They have to be within your purview of caring for them. So again, not something that certainly in our marketplace in New York, we see a lot of. But why is it that we spend so much time thinking about healthcare payment policy? Why, it is certainly complex, but this is a graph that you probably have seen, which is that, we know that we are getting close to spending 20% of our national output on healthcare. We spend a lot of money on healthcare in America. And we also know that our outcomes are not as good as those of other developed nations who spend less. So we're looking for ways to do this better. Some things are easy. This article that Atul Gawande wrote about McAllen, Texas, speaks to the sort of worst end of the misaligned incentives around fee for service, the idea that you do more, you get paid more. This talks about people having, basically being able to get, a cardiac interventional procedure in the supermarket because that's well reimbursed, and there's really no disincentive to do these procedures, but having literally no access to primary care because it's sort of underfunded and not as lucrative. So we know that there are incentives that we need to fix. And there are certainly things that we can look at in where we spend that sort of almost $4 trillion of healthcare system that we should be able to not only influence but shape in the right way. We often think about prescription drugs. I think it's always surprising to people that that's such a small part of the healthcare service. You can see that hospital care and physician services are quite significant. So we know that we've really got a process where we're spending a lot on healthcare. How do we actually decide to the granular level? We know that we're sort of in this fee for service world mostly. How do we decide how much does a chest X-ray get paid versus a CT or an MR? So I'm going to go now into the process of the development of the RVU, the unit of physician productivity. So back to this formula, and you probably heard about RVUs. You do so many RVUs, that's your compensation is based on it. Well, look at it. There's actually 3 of these types of RVUs, 3 flavors of them. So we'll talk a little bit about each of them. But again, this is the formula where we make a service described by an RVU into a payment. So we'll talk more about these RVUs. There's a scaling factor, which is what actually determines the amount. And then we'll talk briefly about this geographic practice cost index, which basically says, look, we know it's more expensive to practice in San Francisco than in rural Mississippi. So there's some slight adjustments. That doesn't necessarily always hold weight. There are some places whose gypsy is kept artificially high so that they can get providers to stay there. So how do we get to those RVUs? Well, this is the process, and we start with the CPT process. So we're over here in this part of the thing. So CPT codes are the sort of the lexicon for us to describe what we do. They are 5-digit codes. The lexicon's owned by the AMA. They make a lot of money licensing it to electronic health records. Our codes are mostly in the 70,000 series, and it's updated every year. There's 3 types. The ones that are sort of in the vernacular of what we do are category 1 codes. Those are things that are FDA approved. They're in common practice. We use category 3 codes as sort of the entree into category 1, new technology. We're not really sure it's going to take off. We're not really sure what it does. And then the category 2 codes are tracking codes. We use them for things like documenting smoking cessation metrics. It's not necessarily something that's going to be front and center for you. So those CPT codes are defined and maintained by a body called the CPT editorial panel, which meets 3 times a year. It has I think still has 17 members, pretty well represented. We have had a couple of members. One, actually, Dr. Thorworth, who's the CEO of the ACR, was the former chair of the CPT editorial panel. So that one's pretty non-controversial. But the next piece, where those CPT codes, which describe the services, are now linked with an RVU value for the essential, like how much are we eventually going to get paid for this? That's where things get kind of complex and controversial. So I will say this guy, Tom McGinty, no relationship. So the body that determines these CPT codes is a body called the Relative Value Update Committee, also known as the RUC. And this is, has been portrayed as sort of, this cabal of physicians, trying to get money out of patients. There may be some certainly there's some optics perhaps that suggest that. But look, I sat on that committee for 4 years. And as you sit on that committee, what you're essentially doing is, as a body of, I think it's now 30 physicians, each representing the major specialties, you are tasked with taking those CPT codes, whether they're new CPT codes or there's a kind of a refresh process every few years of the existing ones, and determining how much they're valued. They are, you're not there as a radiology advocate, you are there as a radiology expert. In fact, as the radiologist on the RUC, I was not allowed to comment on our codes. I could vote on them, but I couldn't comment on them. So, the fact the meetings aren't open is, perceived to be somewhat controversial, but, it is a place, because the meetings aren't open to the public, where people can really discuss these in detail and not feel that they, the eyes of the world are on them. I certainly never went into it feeling like I was going to do anything that was, egregious against other specialties, because I wanted us to be treated with fairness when our codes were coming through. And I'll come back to the third bullet point here, which is that, in essence, one of the reasons why it's controversial is that there's kind of a fixed pool of dollars in Medicare. Medicare only spends a certain amount of physician services every year. So if I, as dermatology, bring a new code and I get a certain RVU value, the money to pay that doesn't come out of thin air. It comes out of what everyone else is already getting paid. So there's essentially, a sense that we're kind of horse trading over a fixed pot of money. Now, we are very, very well represented. As it turns out, the current chair of the RUC is a radiologist, Zeke Silva, and many of you may have heard of Zeke. I have to say, I don't think there were people who thought that they would ever let a radiologist be a chair of the RUC, and it is a testament to Zeke's incredible diplomacy and intelligence and integrity that he is doing that job. But we also have a phenomenal team that supports both the CPT and the RUC committees. Now, the other thing to say about both the CPT and the RUC processes, they are actually they're not Medicare committees. They are American Medical Association committees. They actually are exercising their First Amendment rights to petition the government. That's how they interface with Medicare. So the other thing is, CPT panel creates the CPT code that describes the service. The RUC makes a recommendation for the RVU value. The RUC doesn't decide those, it makes a recommendation. It sends those to Medicare. And Medicare accepts most of those recommendations, but maybe not as many as previously. Oh, excuse me. Sorry, a little COVID coming in there. So let me go back to that thing where I said that, it's kind of a fixed pot of money. And that's this part of the formula, which is the only thing here which actually is a monetary amount. And, you can see that the RVUs, can potentially, stay the same every year. And Medicare can decide how it's going to adjust payment by ratcheting up or down the conversion factor. So again, you don't need to worry too much about that, except to know that essentially Medicare payment is a fixed pot of dollars, which is why the RUC process, where we value new codes and reevaluate old ones, can be so fraught and controversial. Let's talk now about what are some of these RVU values. So CT without, actually, it used to be sort of the kind of foundational RVU was the IVP, which was 1. And when I was a resident, we still had an IVP schedule, and most of you, I'm sure, have never even seen one. But now I think CT chest without contrast is sort of is close enough to the 1 to be the baseline. Everyone knows kind of what that effort is. And then here are some other RVU values. And I show you some ones that are outside of radiology, because when our team is going to this committee to say, here's what we think you should, here's the RVU value that we think you should give for our service. Remember, they're presenting to a group of 29, 30 people, only one of whom is a radiologist, and that radiologist can't talk. So those other physicians are comparing this service to things that they do, and the RVU values, that are associated with what their services are. So, for example, when we were asking for a revaluation of stereotactic needle biopsy, actually we didn't ask for that. Medicare forced us to. We were talking about how difficult a stereotactic biopsy is, and how challenging it is. But remember, there were people sitting around the table who do this, an hour of critical care management, 3.6. Now, I've done some pretty difficult stereotactic biopsies, but you can see that it can be a little bit of an uphill battle to describe some of our services in the context of those provided by the other people around the table. And you can see, obviously, once we get up into the surgical procedures, much, much higher. Now, I showed you in the formula 3 types of RVUs. What I've been talking about here with the process is largely the RVU, which is physician work, what captures the time and effort that you as a physician take to perform the service. An important one for us for radiology is the RVU that captures what we call practice expense. And this is more relevant if you are providing services in an office where you own the equipment and pay the staff, because there's actually a component of Medicare's payment that reflects what you've had to spend to provide the service. It's incredibly important how much Medicare recognizes, for example, for the price of the equipment, because that equipment price is then amortized into every single payment you get from Medicare. Now, of course, they don't do it based on what you in your practice paid for the equipment. They do it on what average radiologists pay for the piece of equipment. And you could argue that because there's a potential benefit to us in radiology for higher prices for equipment, this could potentially be the reason why we are still paying 10 times as much for a CT scanner here in the US as they are in China. Now, I will say Medicare has gotten a little savvier about that element of the practice expense formula, in that when I was first at the RUC, they would just ask you for an invoice from a manufacturer. Of course, everyone knows that's only the start of the negotiation on the price. Eventually, they got smarter and said, we need a retracted, actual contract. And then it's a complex formula, but some of the other things that we've had to deal with in terms of maintaining reimbursement for radiology is, arguing for how much time we're in the room. So, for example, Medicare said, and these are all elements in this formula. Medicare said to us, well, look, we're only going to pay you for the MR time when they're actually scanning. Like, well, doesn't make any sense. Our tech has to take the patient into the room, settle them, do the imaging, figure out, make sure the sequences are okay. So it's probably twice as much time as they're actually scanning. So these are the types of arguments that our team is having, both at the RUC, but also in Baltimore with Medicare. And there's a whole 12-hour day of a committee that decides on this, and you'll hear them going through arcane discussions about, is it 10 cc's of gel for an ultrasound, or is it 12 cc's of gel? And you might think, why is anyone worrying about that? Well, of course, when you extrapolate that over the millions of services that Medicare pays for every year, it starts to become real money. So let's step away now. We've got this, pretty arcane payment policy process, which feeds into a largely fee-for-service system in which we are paid by different payers, everything from Medicaid to commercial insurance. How do physicians seek to influence this process to their advantage, and obviously in the service of the patients that we're tasked with treating? Well, we'll start with our professional organizations. And, it's been an interesting journey. So Harry Truman decided he wanted to try and introduce universal healthcare after the Second World War. The American Medical Association spent more than any other organization in any sphere had spent on any issue. The AMA spent more money to lobby against Medicare in order to not have Medicare. They talked about socialized medicine. This was, so Ronald Reagan, who was still an actor at that point, makes a record that is distributed to the Ladies Auxiliary Committee of every hospital so they can play it, talking about how terrible Medicare is going to be. The AMA's opposition was such, and was so, noted, that when here we have Lyndon Johnson signing the Medicare bill into law in 1965, the only physician group represented is the National Medical Association, the historically Black physicians organization, because the AMA wouldn't allow Black physicians to join. So Montague Cobb, who was the then president of the AMA, was the only physician at the Medicare signing. So we have been advocating and lobbying for many years. It is a significant part of our activities today. Not here to talk about RADPAC, but you know that if you've been to an ACR meeting pre-pandemic, on the Wednesday we have Capitol Hill Day. We go, we meet with lawmakers, we tell them about what we do. We're not asking them specifically on those days. Sometimes we're asking them for specific bills, but we want them to get to know us as radiologists. And we do that at Capitol Hill. People do it with their state legislatures. They can even do it with their city councilors. And I always say, you never know who's going to go from being your, town mayor to a senator. So those relationships are always good. We advocate with CMS. So CMS is the Centers for Medicare and Medicaid Services, administers the Medicare and Medicaid programs. This is the headquarters in Baltimore. So I talked to you about the fact that every fee schedule in Medicare puts out, every piece of policy language is publicly available, and there's a comment period. So at the ACR, what we would typically do is we will write comment letters. So there's multiple page comment letters, but often we will also go to visit CMS, to say that this is what we think is okay in the latest rule. This is what we don't like. Here's what we don't like it. And every specialty does that. There's a Panera Bread across the road from CMS, and you're sitting there and you'll often see like, oh, there's the ophthalmologist, and oh, there the dermatologist. So that's another important part of how we engage with the policy-making process, and here the legislative language. We also seek to influence payment policy through science. So a little New York City sound check here. We also seek to influence payment policy through science. So one of the things I didn't really know about the ACR until I got involved in leadership is that the ACR has a significant research arm, the Center for Research and Innovation, which is headquartered in Philadelphia, and it administers multi-center trials. It does a lot of work for commercial entities, but it administers multi-center trials like the National Lung Screening Trial, which showed enough of a benefit for lung cancer screening with low-dose CT. It was halted early, and it then was evaluated. The results were evaluated by the U.S. Preventive Services Task Force, which gave it the appropriate score so that under the terms of the Affordable Care Act, it needed to be paid for. So we knew lung cancer screening was valuable. We could have just gone and said, please do this. But no, what we did was we did the 50,000 person randomized control trial. So then we were able to get it paid for based on the evidence. We also work with patients, and specifically, I think in breast imaging uniquely, this was First Lady Betty Ford, who very famously spoke about her breast cancer at a time when it really wasn't something you talked about. But the ACR, especially in its path to getting screening covered, and also in its path to make sure that there were quality requirements, has always engaged actively with patients. That is to this day, making sure that private insurance companies paid for tomosynthesis. Those were patient advocacy efforts. So multiple different ways in which we seek to influence the payment policy. So I'm going to finish up with sort of, some stuff about, how should you take what I've told you and think about it in terms of choosing a practice? Well, look, the important thing is what matters to you. Bill Thorworth gives a talk on this and says, you have to think, do I trust these people? Do I like these people? What matters to you? What are the things that drive you? What do you want to be doing with your career? But do know that unfortunately, for good or bad, the mix of these, and they're going to look slightly different in different marketplaces, but the mix of these is going to impact the resources that are available to you. Where you get to practice, so this is something that unfortunately informs our practices and can, for many people, if you have a lot of debt or you're stuck in you're restricted to a particular area, can really significantly inform your choices. I think that we're all learning a lot more about how the payment policy system has really contributed to health inequity. This is an excellent article. Drs. Waite and Scott are from downstate. Dr. Klum was actually at Weill Cornell, and talks about the technology gap, the fact that, if you're seeing patients with Medicaid, you're less likely to afford, higher technology. You're going to make patients travel further to get advanced imaging. If you're in a large health system, as it turns out, the parts of your health system that are in poor neighborhoods are less likely to have the new technology. And, we kind of know that, but it doesn't make it right. In terms of how you're going to get compensated, if you work in an academic institutional hospital, you're typically going to get a salary with some kind of bonus or productivity. I will say actually at Weill Cornell, we're on a flat salary, but you'll probably be getting something based on your productivity, your commitment to the institution, citizenship, administrative responsibilities. Most radiology departments in hospitals make money for the institution. But I think more and more these days, some of the decisions about equipment aren't necessarily as often made by the radiologists. I would say some of the keys to success in this are being, getting as much influence outside of radiology as possible, being seen as a good partner by your peers and by the hospital. Private practice, partnership compensation arrangements vary. Get a lawyer. That's all I can say. It's so important to understand what you're signing on to. Definitely, especially with the pandemic, as well as some of the reimbursement cuts that we saw in the mid-2000s, smaller practices have been challenged, but that doesn't mean there aren't successful small practices. The ones that I see around the country that are successful are deeply engaged with their hospital systems and their referring physician community. Private equity, whole other talk. I know this is a subject of great concern to our trainees, and I was really thrilled that we had a resolution passed at the recent ACR meeting that really encourages transparency for trainees coming into practice, and then removal of restrictive covenants for those where there's been a significant change of control if the practice is sold after they've joined on. And look, private equity, as I said at the bottom, it is what it is. It's about investing, it's about return on investment. And, yes, you may see these private equity groups holding some of their investments in imaging centers longer, but they will eventually exit. They will eventually sell. RadNet or VRAD has had multiple different owners, and for many physicians working there, that doesn't really impact them. But the model typically pays out to the senior shareholders, discounts the work that you will do after the acquisition, so it's not as favorable to mid and early career physicians. There's definitely an expectation of efficiencies. I mean, I've heard about productivity, not just productivity targets, but being timed when you go to the bathroom. It's not evil, it is what it is, but just specifically, I think really avoiding restrictive covenants is critically important, so that if it doesn't work out for you, you're not stuck not being able to go somewhere else. I think, it's just about, honestly, having a strategic plan. What are your goals? What do you want to do? Where do you want to work? And then a scenario plan that says, well, how do I make my plans as adaptable as possible so that if things don't go right, then I know I have choices. So in terms of what's ahead for radiology reimbursement, we are seeing a shift to pay more for the E&M services that our primary care colleagues, pediatricians give. And the ACR has been very actively opposing that. Why? Not that we don't want our primary care and pediatrician colleagues to get paid more. I'm married to a pediatrician, but go back to what I said about a fixed pool of dollars. It means that we're going to take money out of many other specialties. So what we want is those specialties to get paid better, be reimbursed more fairly, but it needs to come from extra money. You may have read about price transparency legislation, which is something that one of the few things that sort of has survived the Trump administration into the Biden administration. Seemed like a great idea. We want our patients to be able to see what they're going to pay out of pocket. Unfortunately, the insurance companies have gotten in there and really distorted it to their end so they can negotiate more aggressively with providers. And the ACR, as you may know, has actually sued with the emergency physicians, and the pathologist has sued the federal government on that. That we're seeing advanced practice providers, not radiologist assistants, let me say that, but NPs, other APPs looking to expand scope of practice. They just got that passed in New York. And then, of course, the idea that, we're starting to see AI coming into our practice. How are we paying for that? As I said, I don't think it's going to go well for us if we're paying for it through fee for service, because it's going to be a lot cheaper than us. And then, of course, we do still continue to hear now and then about single payer. Our Secretary of Human Health and Human Services, Javier Becerra, was actually a big advocate for this as a senator. President Biden has not espoused it, so I don't think we're going to see it put forward anytime soon. So I said that this was everything you ever needed to know about healthcare payment policy. Well, why do I say that? Well, certainly the focus on productivity, without really, as I say, the V not standing for value the way we think about it, I think has led to a lot of overuse in some areas. The fact that fixed pot of dollars, I think, has perhaps impeded our attempts as physicians to work collaboratively together for our patients. I think we're seeing some of the burnout that's associated with these productivity-based comp models. And overall, I would say that the misaligned incentives often outpace the good intentions of most physicians. So I've given you an awful lot, and I hope that you're feeling as if you're well represented by the ACR, but your involvement, whether it's locally in your institution or with the ACR, is critical. Volunteers lead ACR's participation in these payment policy processes. The Medicare process, as I said, is open for comment. Our continued legislative efforts with commercial payers, with price transparency, are going to depend on a pipeline of volunteers. So as I said at the beginning, it's complex. You're well represented, but please get involved.